Good afternoon, everyone, and welcome to this first A2A mini webinar hosted by the European Patient Safety Foundation. For those who don't know me, I am Mirka Cikelova, General Secretary of the European Patient Safety Foundation, and I will be moderating today's webinar. And I will start by giving a huge thank you to Professor Reinhard Stramett. So Reinhard, thank you very much for joining us today, and also to thank you to our affiliates or members of our organizations affiliated to EUPSF for joining this new adventure we are starting. So the A2A stands for Affiliate to Affiliate, and we launched this series because we believe that there is a lot of knowledge, experience, and also innovative practice being developed or tested across Europe. And by sharing these insights, pilot programs, or lesson learned among our affiliates, we can help each other save time, avoid duplication, and most importantly, accelerate change in the field of patient safety. So, and there is another purpose behind this webinar. So it's to build a strong community of patient safety experts actively involved in the work of the foundation. So we hope to strengthen the connections between affiliates by offering a space to meet, to exchange, collaborate between our annual conferences, and ideally around a specific topic, so that we are driving meaningful progress across Europe. So this session will be focusing on the economic implications of peer-to-peer psychological support programs for healthcare workers. And while the phenomenon of the second victim is now widely recognized, that is less visible. What is less visible is how investing in structured support can also bring measurable economic benefits. And this is highly relevant to patient safety, because when the human cost alone isn't enough to prompt the action, and which is unfortunately often the case, the economic arguments can help drive change and at managerial or organization levels. So hospital leadership, heads of departments, and decision makers are more likely to implement support programs when they see not only their ethical necessity, but also their financial benefits and impact on staff turnover, absenteeism, and ultimately the quality of care. So our close involvement in this topic is also linked to the EARNST network, which is the European research network working on second victim, which was co-chaired by Reinhard. And this network received our very first Butterfly Impact Award for patient safety during our last year's conference, as a recognition of its outstanding work. Through the award, we aim to help raise awareness and reinforce the importance of supporting healthcare professionals after adverse events. And just a quick side note, we have just launched the second edition of the award. And again, this year, we are looking for evidence-based, innovative practices that have a real and measurable impact on patient safety, especially through so-called butterfly effects. So something that is very easy to adapt and implement in some other countries and settings. And we are concentrating on low-tech or open source solutions. So if that sounds like something you are working on, or you know someone working on a very good practice, please encourage them to check the website of the European Patient Safety Foundation or the conference. And remember that the deadline for submission is Monday, 1st September. So just a few house rules. During the presentation, please use chat for asking your questions. I will then bring them forward after the presentation. After presentation, we will just have an open discussion in our small community. We are recording the official part of the presentation. Well, recording the whole part, but we will be sharing only the official presentation part, and the open discussion will not be shared afterwards, so that we can have closed space for exchange between affiliates to reflect, connect, and discuss in a more community-like environment. So the session, we planned it for around 1 hour. And thank you again for being with us today, and I hope you will enjoy this moment. So now let me welcome one more time Professor Dr. Reinhard Stramett, who will guide us through today's webinar. Professor Strames is an anesthesiologist and health economist with extensive experience in quality and clinical risk management, as well as emergency medicine. He was medical director of the quality management unit at the Frankfurt University Hospital, and he's now professor of patient safety at Wiesbaden Business School, head of Wiesbaden Institute for Healthcare Economics and Patient Safety, and also vice chair of Cost Action Supporting Emerging Care Economy, empowering caregivers to provide safe care at home, which is called also Better Care. His research and work have significantly contributed to understanding the second victim phenomenon and building the case for large institutional support. And I now pass the word to Reinhard.
Thank you very much, Mirka. First of all, for the invitation, and second of all, for the kind introduction. Dear affiliate colleagues, thank you very much for joining me today. I have to admit, I did a lot of B2B and B2C activities, but this is the first A2A activity I ever do. So it's kind of a premiere for me as well. And I'm very honored that the economic value of peer support programs in healthcare will be the ignition of that A2A webinar series, and I hope it will be a success. So I was briefly introduced. Before I start the presentation, let me give some potential conflicts of interest because there are some sources mentioned during that presentation. It is my great pleasure, as already announced, to be the vice chair of the closed EU Cost Action Ernst, European Researchers Network working on second victims under the great leadership of Professor José Mira, who is also joining us today. So, hola, José. ¿Qué tal? I'm the vice chair of the EU Cost Action Better Care, and I'm also proud affiliate, or we are, as we have, also proud affiliate of the EU PSF. During my activities and my research activities, I had the privilege and honor to advise the German Ministry of Health on what to do about the second victim phenomenon, what is in their power to do, which has already influenced the federal social court regulations. And I have also the honor to evaluate some of the bigger projects where my institute also got some funding, which may be a potential conflict of interest. So we evaluated the PSU Bavaria project, and I'm also the lead evaluator of some projects in Vienna for one of the hospitals there, and also for the whole Vienna Hospital Society or Health Society, which are now doing a rollout of peer support programs, which of course is a good opportunity also to get new data to see the real economic benefit we can achieve. So the Wiesbaden Institute for Healthcare Economics of Patient Safety is abbreviated with the name WeHelp, and that is not a coincidence. And we are focusing on a multi-level approach on building resilient healthcare systems, starting with a systemic resilience to strengthening healthcare systems and healthcare policies, up to the individual resilience, which may be related to workforce retention in order to keep as many healthcare professionals healthy and happy in their jobs, so that they don't leave early, but retire at a regular age and help to sustain the healthcare services across the European Union or even beyond that kind of borders. And our institute consists of a lot of researchers, 7 professors, 4 doctoral students, and they are basically concerned with the fields of medicine, economics, policy, law, management, human resources, supply chain management. So it's a truly multi-professional approach we can have in order to answer multidisciplinary and complex questions in healthcare. So let me briefly remind you, because not everybody may be involved into the terminology of second victims that much, that a second victim may be defined as any healthcare worker directly or indirectly involved in an unanticipated adverse patient event, an unintentional healthcare error, or a patient injury, and who becomes victimized in that sense that they are also negatively impacted. So it could be an honest mistake leading to becoming a second victim. It could be a near miss where there is no first victim at all. It could be a mass casualty, for example. It could be a terrorist attack. It could be personal violence against. I'm sorry, somehow the presentation develops an own life. It could be an approach. There could be multiple approaches why you can become second victim. So we have to keep that in mind. because we know a lot about the phenomenon, and we also know that different professions may suffer from the same problem, but they have different pathways entering to become second victims, for example. But nevertheless, the symptoms can be compared, and also the burden, the negative consequences, and the strategies to come out of that second victim phenomenon, they can be compared, whether it's an unintentional error or whether it's anything else that's way beyond the influence of a second victim at all. So briefly, what we know about second victim phenomena, especially in German-speaking countries or in Central Europe, we know that most of the doctors and nurses who we survey concerning second victim phenomenon don't know or haven't known the term yet. So if we ask them, did you ever know about second victim? They say, no. What is that? And then we explain them what a second victim is. And then the majority says, well, I have been second victim in my medical career before. So this is the first important information, that there is a lack of awareness among clinical healthcare workers about the extension and the impact of this phenomenon, which makes it difficult to implement programs. And we have to consider that as well in order to lift the whole economic impact of that. And we also know that roughly 1 in 5 second victims will not recover fully to their own description. So it takes them more than 1 year, or they say, I've never recovered fully, leading to presentism, leading to absenteeism, and also leading to turnover. We also know that regarding the severity of the symptoms, we face overconfidence and overplacement effects. So we are trained as healthcare professionals to say, well, we are the tough ones, we are the healthy ones. So it is expected among our peers to cope with that situation, more or less, and not to say, well, it's okay to seek for help, which is another barrier we have to consider when we talk about the economic impact. And we also know that 2 out of 3 second victims will discover dysfunctional coping strategies like substance abuse, like defensive practice, like isolation, up to PTSD or turnover, if they don't get any professional help at all. So this is a huge body of evidence in Europe and across Europe. And we know that this is more or less the same in every country we assess the phenomenon. So in some countries, it's 85%. In some countries, it's 68%. In some countries, it's 63%. But the absolute majority of healthcare workers we survey will say, I have been second victim myself. And roughly 10 to 20% of all second victims will say, I haven't recovered fully from that incident. So it's the same in Austria. We have assessed that also with the CEVIT questionnaire, our instrument. In other countries, like Estonia, like Malta, like Italy, like Portugal, and everywhere and every time we assess this, we will get these kind of results. So it's a very stable phenomenon, whether it's intensive care, whether it's general practitioners, midwives, nurses, you name it. So every profession will be affected by that. It's not only the emergency department or the emergency medical services, it's every aspect of healthcare who can be involved. So we also know, thanks to the work of Susan Scott, she found out in 2009 that there are more or less 6 stages how we are living through the second victim phenomenon. And for me, the most important aspect of that is that there are 3 possibilities to come out of that situation. It's either by thriving, by growing, by becoming a better nurse, a better doctor. It's by surviving, walking wounded and suffering in silence. You can compare that to a doctor, for example, compared to Dr. House in the series. So apparently a nice guy in former times, but now severely affected, also with negative consequences towards patients. Or the worst case would be dropping out of the system, like leaving the hospital, leaving the workplace, or even leaving the profession. And that could be the option. And we also know from extensive work, one of the works I would like to cite is an extensive work by Deborah Sayce and colleagues. I had the honor to be involved in that there are preventive measures who can prevent of second victims of surviving or dropping out, who can ensure or support thriving from that situation. And the most important pillar of that is peer support. It's peer support for two reasons. First of all, it's available everywhere. So we are very short of psychologists and psychotherapists, not only in Germany, but across Europe, but colleagues are always there. So the availability is there. And second of all, the barrier to open up towards somebody is minimal to a peer compared to a psychologist. Because a lot of doctors, and I was a doctor myself, would have said, well, I'm a doctor, I don't go to the shrink. I'm not a psycho, so I don't have to go there. So it's still a huge stigma to open up for help in medicine and healthcare, but it's even worse if it's not a colleague, but any other profession I have to open up. And thirdly, I have to explain them how an intensive care unit works or how an ambulance car works, the psychologist. And of course, the peer who has been there, who probably has faced the same experience previously, can help way better because he or she will perfectly understand how I feel. And by the way, speaking from the dark side of medicine as an economist, it's also way cheaper to get help from peer supporters than to send anybody and everybody to the psychologist. Yeah, it's not feasible and it's also not affordable. So we are focused on the peer support program, and there is another publication I want to draw your attention on when it comes to economics of patient safety, because the OECD has launched in 2017 a series which is called The Economics of Patient Safety. And I can highly recommend this to anybody involved in patient safety because it also gives arguments to go to the dark side of power, to go to the economists, because now they systematically assessed how much money is burned, is wasted annually due to unsafe care. It's not a matter of how much patient safety will cost. It's a matter of how much patient unsafety will cost us every year. So it's the opportunity cost we have to keep in mind. Patient safety is the 14th leading cause of global burden and disease, and it's estimated that in the inpatient sector, 13% of health system expenditure is attributed to treating safety failures in high-income countries. In low-income countries, it may be even more. So a lot of the health budget in low-income countries may be attributed to patient safety incidents. But in Germany, for example, speaking about 13% of health expenditure would add up to more than 60 billion euros annually. And I don't want to be the bad guy talking about saving money. I just want to say how much things could we do better if we spend the money more reasonable. In the UK, for example, they calculated that they could employ 2,000 general practitioners or 3,500 hospital nurses in addition, just by getting rid of patient safety incident costs. So how could we support this system way better if we do it right in the first place? And the good news is that most burden is associated with a few common adverse events. So we can also focus on some of these events to save a lot of money that can be used better for patients, a lot of resources that can be used better for patients in order to increase patient safety. So there are a lot of publications, and I don't want to go through all of that because then we wouldn't have the time. But there's one paper I would also recommend to you because it's also the economics of health worker safety. It's part 4 of that series. And it was stated that healthcare settings are inherently hazardous. So it's dangerous to work in the healthcare sector. And it's not so because there are explosions and bullets and other things, but most of the problems for high job turnover, dropout rates, and level of absenteeism include interpersonal violence and mental ill health. So it's not on the physical side of occupational health care where we have lots of room for improvement because we did that in the past decades and centuries. So the physical conditions of working are way safer now in the hospital than they were 50 years before, but the psychological conditions have not been addressed that well. And these hazards, and it's clear, they also jeopardize patient safety. Just if you think about a person having burnout, will probably have an increased failure rate by up to 600%. So they will 6 times more likely be making a mistake than if they are healthy. So investing in health worker safety is also investing in patient safety. And improving well-being would lower the costs of health spending by up to 2%, which in Germany would be equal to about 9 billion euros annually if we have an improvement in all occupational circumstances, not only the second victim phenomenon, of course, but also among others. But I think you have to keep that number in mind just to see the external validity of our study, how much of these 9 billion euros could be attributed to the second victim phenomenon. I will come to that later. So in 2017, Moran and colleagues did an economic analysis based on the RISE program of Johns Hopkins University, invented by Albert Wu and colleagues. And basically, they found out under their assumptions that if any nurse would grab the phone and call the RISE hotline, the hospital would save $22,576 per call, because they were able to reduce turnover rates. And also in the United States, if you have to employ another nurse or another doctor, only speaking of direct costs, not speaking of the indirect costs like the ramp up, like the loss of experience and all that, but only the direct costs, that would add up to $100,000 per nurse. So it's extremely costly to lose staff and to hire a new one until they are there and they can work on a full basis. So we have to keep that in mind, because this is basically what is the key success for the economic evaluation. So based on that, we had 2 research questions, and I'm happy to present these research questions now, because 2.5 weeks ago, my doctoral candidate, Hanna Rösner, was successfully defending her thesis, supervised by Professor Jose Mira and myself, in Alicante in Spain. So some of the slides are provided by Hanna Rösner, and I want to thank her, give full credit to her work, because what we have found out is basically her PhD thesis that was successfully defended 2.5 weeks ago. So first of all, we thought about the macro perspective, the macro perspective, because it's nice to see that the healthcare system can save money. But of course, first of all, you have to convince the hospital director to invent that program, because you have to say, well, do I save money with my hospital if I implement a peer support program? That's a much more realistic and down-to-earth question. So this is the first study. We have assessed how does the implementation of a peer support program impact absenteeism, turnover rates, and financial costs in German hospital settings. And the next one was the macro perspective. If we think about what we know about the second victim phenomenon in Germany, what kind of impact would have a peer support program if we think about a nationwide implementation of peer support in whole hospitals? So what is the total economic benefit we could have if every healthcare institution in the inpatient sector would have peer support by the year 20 whatever, just to see the economic potential of that. So these 2 studies I would like to present, and I'm happy for any questions that you have afterwards. So starting with study number 1, this was a healthcare economic evaluation based on a scenario hospital. So we thought of a typical German hospital, not a university hospital, which is not the majority of hospitals, but a typical German hospital, which will have around about 1,000 nurses. These are not full-time equivalents, but heads, people working as a nurse, and roughly 550 beds. So a medium-sized hospital. There are smaller ones. Of course, the university hospitals are bigger ones, but it's a medium-sized hospital we have assumed based on our scenario. And of course, there were previous studies. First of all, there were the study of Moran, which had some assumptions based on successful peer support programs implemented 10 years, 15 years ago in the United States. And we also had to consult experts, because of course, there is no statistic on saying how much will it cost to reinstate the position of a nurse, so to hire another one. But of course, HR departments of German hospitals pretty much know how much it will cost them in order to replace a doctor or in order to replace a nurse. And they did, and we called them and asked for their expert opinions. And the numbers were had a narrow confidence interval between the hospitals we asked. So what we did then was a Markov model to assume certain probabilities of conditions that will be achieved. It was operated on a daily cycle base, and we calculated that for 365 cycles, so for 1 year, to estimate the annual cost you could save with a peer support program. And based on that, now it's getting a bit tricky. Based on that, we set up a model. So for a healthcare economic model is quite simple, but of course we have to explain it. So we estimated the probability if a healthcare worker comes to work every day, what is the probability that he or she will have a high impact event? And what is the probability that he or she will remain unaffected, that he or she will have to take at least 1 day off, or that he or she would say, no, I will quit the job. And of course, for the next day, we have to consider the state from the day before. So when I was unaffected the day before, the probability of staying unaffected the next day is quite high. If I had to take a day off on the first day, the probability of taking another day off is, of course, higher than to recover. And if I have decided to quit, then I'm out, because we did not assume that somebody who said, well, I quit the job will come back in that. So that's kind of a simplification we had to make in that kind of model. But we considered only in that model the so-called direct costs. So we considered the cost of absenteeism. In Germany, the employee has to pay for the wages of somebody if he or she falls ill from the first day. So they get their salary on a normal basis, but of course the person does not come to work. So it's a minus for the employer, of course. And the other thing, which is the bigger minus for the employer, would be if somebody says, I'm quitting, I'm leaving, because then I have to invest quite a lot of money in order to fill this kind of position for a nurse or a doctor. And so based on previous estimations and expert estimations to make it a bit more conservative, these were the probabilities we had assumed. So we assume that every health employee has a 2% chance of being confronted with a high impact event every day. This does not mean that 2 out of 100 employees will be affected, but the probability of facing a high impact event will be 2%. Like if I come to work on 100 days, there will be at least 2 days where I've seen something that could be potentially harmful, which is, I think, still a conservative approach if you think about emergency medical services or emergency departments. And after this high impact event, the probability of a sick day was assumed to be 5%. So after having a high event, 5% of the healthcare workers said, well, I have to take a day off. And the probability of resignation was 0.68% after having a high impact event. And we assumed that introducing peer support would reduce the probability of a sick day moderately from 5 to 3%, and the probability of resignation to roughly 0.354%. So it's a basic estimation that you cannot avoid any resignation and any sick day with peer support. So there's no 100% chance, but it's estimated that you could mitigate the effect by roughly more or less 50%. So that you could more or less halve the absenteeism days, and that you can more or less halve the resignation incidences. So you halve the turnover. And as I said, only direct costs were considered. We did not talk about beds that cannot be run on ICU. We did not talk about operations that cannot be performed in a theater, leading to lose money. We did not consider any negative satisfaction of patients or reputation damages or whatever could come with that. So it's only the direct costs. We said we want to have a very conservative approach because we know it's a simulation, it's an assumption. It's not real world data because it's not possible to measure somebody who said, well, without that peer support, I would have quit, but now I will stay in my job. And now I wanted to tell you that in order to survey that. You cannot survey that, but you have to make assumptions. And that's why we chose to be very, very conservative in our assumptions. So the true numbers might be higher. So if we have any kind of error, we always try to underestimate the effect and not to overestimate the effect. So the true numbers may be even higher, but coming to the numbers, I guess they are already high enough. Yeah, by making return on invest. But we have to keep that in mind. But when it comes to that kind of calculations, we always want to be on the safe side. So we always want to underestimate the effect and not overestimate the effect. So everything we see is not a big drama, but the true numbers may be even higher. Whether it's 20% or 50% or 200%, I don't know. But if they are not correct, they may be higher. So if you see the distribution about the costs, you see the aggregation, you see the blue columns without peer support program, you see the orange columns with peer support programs. And first of all, the good news is that for the majority of people, it has no effect, because the majority of people will not be affected by the second victim phenomenon in a sense that they quit the job, for example. That's the good news. Everything else will be unrealistic. But you see this peak in the left picture with 80,000. And this clearly represents the resignations. So it is estimated that if a nurse will resignate and has to be replaced, it will cost a German hospital, according to HR specialists, not according to my data, but HR specialists, it will cost roughly 75,000 euros to reinstall another nurse on that position. The cost for a medical doctor would even be higher. It would be sum up to 150,000 euros. Now, I'm fully aware that Germany is a very high income country and that these numbers could be different in other countries in Europe. But nevertheless, we could have significant costs for the hospitals in order to replace the doctors. Also taking into account that there is an aftermath of indirect costs, because if you lose a doctor or a nurse, you certainly also lose the capacity to treat patients or to run operations or to do whatever at a certain extent. So this will add up to that. You see, the days off are not contributing that much to the total costs. And you also see that there is not that huge difference between the blue and the orange column. You see it's more likely with peer support to have 0 or at least a few days off. But there's not such a huge difference if it comes to the length of stay. But you also say there's a significant number of people that have to take a day off for 20 days, for 30 days, or even for 40 days, which aligns with our findings from the health insurance companies that psychosocial conditions are the most common cause of absenteeism in healthcare in Germany. So it's not like back pain or musculoskeletal diseases or injuries, but it's psychosocial diseases or inabilities and capacities, because they add up to a large number of sick days in a row. And you also see the big difference with peer support program and without peer support programs by means of resignation, because it's proven in other studies that peer support programs and peer support itself can have a dramatic impact on reduction of turnovers in healthcare staff. So calculating that for 365 days for 1 year, for that scenario hospital with 550 beds, we estimate to reduce the number of sick days for roughly 625 days, which is not that much because a sick day does not cost that much. But we could also reduce the dropouts from 143 to 58. And if you consider that the dropouts will add up to 75,000 euros per dropout, you see the cost of dropouts are significantly reduced. That would reduce the total cost for that hospital by 6.6 million euros annually. And here I'm speaking of the budget of the hospital director. So it's actually real money he will lose at the moment. And so you could, per nurse, you could save roughly 6,672 euros. Only talking about nurses, not talking about doctors. So there would be an additional benefit, of course, if you run the program, because its peer support program is not only for nurses, but also for doctors and other health occupations like midwives and medical technicians, et cetera, et cetera. And you see implementing such a program would save 6,672 euros per nurse. Now you have to consider that if you run a peer support program, you probably have to employ somebody who is running that. You probably have to have a contract at least with a psychologist. And of course, you have to train the peers, which also would add up to some of the expenses. But we would estimate that you would have to invest roughly 50 up to 100 euros per nurse, and you could save 6,600 euros per nurse annually. So if you go to your hospital director saying, give me 100 and I give you 6,600, that will be a good deal. Probably everybody would agree on. And so now at the moment, we are talking with a lot of hospital directors because this took their attention, of course, because this is something they really can save money within a short period of time, let's say 2 years or 3 years after the program has been launched. So let's switch to study number 2. What would be the assumptions for Germany? We are very fortunate that we are able to have run 10 studies of the second victim phenomenon prevalence in Germany. So we assessed internal medicine residents, we assessed nurses, paramedics, emergency dispatchers, what else? General practitioners, of course, anesthesiologists. So different kinds of people. And within that, we also asked them, how long did it take until you have fully recovered? Was it less than a day until you were fit again for work? Was it within a week, within a month, within a year? Or was it more than a year? Or haven't you ever recovered of that? So, and you see the proportions here given by the CEVIT 1 and 2 studies, which were published in 2019 and 2020. So now we assumed, also in a conservative way, and I tell you why, we assumed that every day of infection would be a day of absenteeism. So that sounds weird at the first moment because probably most of them would have shown up for work instead of staying at home for a month or a year. But if you consider that showing presentism, so going to work emotionally affected, would cause even more damage than staying at home, because you are more likely to make capital mistakes that sum up to the 13% of health expenditure that is wasted annually due to unsafe actions, then you see it's again very conservative to say everyday affection would be calculated as a day of absenteeism, because a day of absenteeism would even be cheaper than a day of presentism. And of course, we assumed that everybody who said, well, I have never recovered at all, would be a candidate to drop out within the next year, because this is the most drastic and the most chronic condition that can be described in the survey. Again, we also only focused on direct costs like absenteeism and turnovers. We also did not take into consideration any other costs like reduced productivity, lack of moral, lack of safety culture, complaints by patients, whatever could add up to that costs again. So again, we think it's rather an underestimation, but an overestimation. So giving that, also making a sensitivity analysis, calculating a lower and upper limit of effectiveness, we estimated that we could halve the number of people in the respective class and put them to the next best class upwards. So what does that mean? So if, for example, we have 32% without peer support program among the physicians that are affected 7 days, we estimate that we could reduce that number by 50%. So 50% would move up one class and would only be affected for 1 day. Or those who are affected for 1 month would move to the class being affected only for less than 7 days. So estimating that, also considering a sensitivity analysis of a 25% effectiveness or a 75% effectiveness of that program, we calculated the reduction of people's absenteeism days, and we calculated the reduction of people who will suffer for more than 1 year and are most likely to drop out of the system. And again, it is known what an absenteeism day for doctors and nurses will cost in Germany on average, based on the insurance data. And we will know how much it will cost to replace a nurse or a doctor. Giving that numbers, we calculated that for physicians, the total economic burden of second victim phenomenon now, without peer support, will add up to 1.56 billion euros annually. And we could realistically reduce that to 0.86 billion euros annually. So still there would be like 860 million euros annually in Germany having to be spent because of the psychosocial burden doctors will have, but we could lower that by 0.7 billion euros annually. And for nurses, as there are more nurses employed than doctors, of course, in the inpatient sector, we could lower that from 1.87 billion euros to 1.02 billion euros. So in total, we could save 1.55 billion euros annually if a peer support program would be implemented in all inpatient care sectors in Germany. And of course, giving the fact that the doctors and nurses would also be willing to participate in that kind of support programs. So we also would have to add some of the resources to raising awareness and also lowering barriers to talking to somebody, which can be most easily achieved by doing that with peer supporters, of course. So 1.55 billion, and that would be the proportion of the roughly 9 billion euros OECD previously found out could be saved in high-income countries like Germany annually. So 2% of health system expenditure would be 9 billion euros, and 1.55 of that 9 billion euros could be due to the second victim phenomenon. So it's of course not the only problem we have by means of psychosocial burden, but it's one of the most prominent that is a good target field for investment. So both of the studies have been published open access. So I'm very happy if you download them, if you comment on them, if you have any questions. Anna Rüssner and I will be more than happy to answer that kind of questions. And I hope that these studies will also close an important gap we have faced in implementing patient safety measures, because it will end the debate of how costly it will be to implement such a program, shifting towards the discussion, how many euros can we save in the next 2 years if we do it now? And if we want to say we have to do it now, I have learned when I was in Tokyo last year that there's a much more polite expression to tell that the roof is burning and that we have to take immediate action now. It's the simple Japanese quote, "The best time to plant a tree was 20 years ago. The second best time is now." So now I'm looking forward to any questions and discussion, and thank you very much for listening to me.